Good afternoon, everyone. My name is Sharon Rounds. I'm the PI for Advance-CTR, and we're delighted today to have a guest speaker for our Advance-CTR Translational Research Seminar Series, which this year is focusing on distinguished clinical and translational scientists from our partner institutions in Rhode Island. So today we're very pleased to have Dr. Kimberly Arcoleo with us. Kim is a professor in the College of Nursing at the University of Rhode Island, where she is also a director of research. She comes to Rhode Island from Rochester, New York, where she completed her PhD and MPH degrees. She is has a health services researcher who's been working in the area of health disparities, particularly with regard to pediatric asthma. And we're delighted to have her here with us today to discuss her work on school-based asthma therapy to reduce disparities in childhood asthma. And she'll be discussing pragmatic process and program implementation evaluation. So take it away, Dr. Arcoleo, and thank you so much for being with us again today. And by the way, attendees, put your questions, comments in the chat, and we will be addressing them at the end of the seminar. Thank you.
Thank you so much, Sharon, and all of the rest of the Advance-CTR team for giving me this wonderful opportunity today to highlight some really important work that we are doing actually in Columbus, Ohio. It started back when I was there at Ohio State. So what I'd like to do first is kind of go through how we got the program up and running in Ohio, which was more of a quality improvement initiative based on some peer-reviewed RCT data. So I arrived at Ohio State in 2011 and got connected with the asthma group at Nationwide Children's Hospital. It was called the Asthma Keep Me Well Initiative, which was headed up by Dr. Beth Allen and Dr. Sean Gleason. And what that group was seeking to do was broaden the services that they provided to children with asthma beyond the hospital walls in the ambulatory clinics. Beth is a pediatric pulmonologist, and she was the physician lead. And we used to meet every Friday. And so one Friday she came and she had 5 or 6 different articles, different peer-reviewed programs that had been implemented more out in the community. Some were in schools, some were just community-based for the group to review. And lo and behold, one of them happened to be the school-based asthma therapy program, which was developed at the University of Rochester by a dear friend and longtime colleague, Dr. Jill Halterman. So I set up several conference calls. We met with Jill to talk about what would we, as this Asthma Keep Me Well group, need to do if we wanted to do a real world implementation in the city of Columbus. So we had a number of calls with her. We had to talk about where would we get the initial funding to launch this? How were we going to actually approach the school districts? There were a lot of, I guess you could call them background kind of fact-seeking initiatives that we had to do. So one of the things that we opted to do was the unique model that exists in Columbus. It's really great. Is there is a physician hospital organization known as Partners for Kids, and it is a collaboration between Nationwide Children's Hospital and this over 900 member physician network. It's the oldest and largest pediatric accountable care organization in the US. And the intent was it was created in 1994 to serve children in South Central and Southeastern Ohio And it's actually now has broadened out to go even further west into Dayton and up into Akron in the Cleveland area. And they now to date are responsible for about over 500,000 children all across the state of Ohio. So we met with them, we presented this program to them. There was buy-in from the PFK leadership. At the time, Dr. Gleason was not the CEO, he is now. They felt that the approach of directly observed therapy, giving the kids their asthma control and medications in school was viewed as a major benefit. They liked the fact that it was a coordinated care model between the child's primary care or specialty care physician, the school health services team, and the hospital. It was a good fit with the existing resources that Nationwide Children's and Partners for Kids had. And there was the benefit that Jill and I have been collaborators since the early 90s. So there was already a well-established working relationship there. So some of the things that we needed to do before we could even begin thinking about enrolling our first child in the program was to talk to administrators of the two largest school districts in Columbus, and that's Columbus City Schools and Southwestern City Schools, to see what's your interest and support for us being able to come in and implement this program in conjunction with your school health staff. So Dr. Allen literally was the boots on the ground person, and she was holding individual meetings, luncheons. She did it with community providers, school administrators, specialty care providers, to actually describe what the program was and solicit referrals to the program. While she was doing that, Dr. Gleason worked with, at the time, the 7 Medicaid plans that Partners for Kids administered under their umbrella in order to get, approval for 2 controller medications per month for the child, one that we would have at the school and then one that could be at home with the child. Then we also had to create a mechanism within the outpatient pharmacy at Nationwide Children's Hospital for being able to process and distribute all of those medications. The next thing that we did is we hired Courtney Rowe, who was a pediatric nurse practitioner, to assist Dr. Allen in recruiting schools as well as training the school personnel. What's interesting here is the 2 school districts that we ended up collaborating with have different models of delivering their school-based healthcare. In Columbus City Schools at the time, there were the school nurses that rotated among schools. So they were not in, each school did not have a full-time nurse all day long. And in many cases, the school secretary served as the backup for when the nurse wasn't in school. But in Southwestern City School Districts, they had a model where each school had a medication monitor in the school 6 hours a day, and they worked under kind of the rubric and the supervision of the school nurse, which was assigned several schools. So very different models of care. So, but Courtney trained all of those individuals who were responsible for administering this program. Also, she and Dr. Gleason had to work with the legal team at Nationwide Children's Hospital and the Ohio State Board of Pharmacy to get a waiver. And here's what was really strange, and something that in our current project that we're thinking about as a tool for people to consider. At the time, the Ohio State Board of Pharmacy would allow Nationwide Children's Hospital to mail the children's controller and quick relief medications to the home. And we know that many of these families are quite mobile, so we didn't even know, were they actually getting to the right family, who was getting the medication. But they were not allowed to mail it to the school where the nurse would actually sign for the prescription, which was an odd law on the books. But it is what it is. And so we had to figure out what's our little workaround for this while we applied for this waiver that would allow the outpatient pharmacy to mail those prescriptions to the schools. So Courtney actually served as our courier in terms of delivering that in the short term. Dr. Allen also had to work with the legal teams at the hospital and at the school districts to craft a consent document that would allow the caregivers and the kids to give consent for the child to participate. We call it SBAT, in the SBAT program, but also allow access to health and school record data so that we could start to monitor the effectiveness of this program. So in 2013, we were finally ready with all of those background activities. So as you can see, it took us almost 2 years to get through all of the kind of groundwork just to support the launch of the program. So Dr. Allen and Courtney provided the training to the school personnel on guideline-based asthma care. They went over the processes for how to recruit and refer kids to the program. They actually trained them on the actual administration, directly observed administration of the medications during the school day, and then what documentation would be required in preparation for us to do that initial launch. So as I just stated, in the beginning, before we got the waiver, Courtney would actually spend Mondays driving around to all the schools, delivering the meds so that we could get the program up and running. Once we did get the waiver, what we decided to do is that upon initial enrollment for the child, they would still hand deliver the meds so that we could review all of the, instructions for administration, documentation. But subsequent refills, we were then able to mail home and mail to the school nurse. We created an internal tracking system for the SBAT program so that we could see who enrolled, how long they were in the program, did they re-enroll the subsequent year. Our SBAT nurse, Courtney, and then over time we added more nurses to the team. They actually served as liaisons with the child's healthcare provider as well as their insurer to make sure that any prescribed medication changes were communicated, any requests for refills were processed in a timely manner. And then the other thing that the nurses did is they prepared what we called summer take-home bags for the families. So the nurses prepared, written instructions for how to continue the medications over the summer, how to contact them to get refills. Our SBAT nurse team worked over the summer in case refills were needed. Scheduling asthma provider follow-up visits so that they would have those done before the school year started. And then we also included in that package a consent form for the caregivers so that if they did want their child to re-enroll for the upcoming school year, we could get that completed and sent back. It just relieved a little bit of burden at the beginning of the school year on our nursing team. And we offered a very, very small compensation if they returned that consent document early. So this schematic just kind of shows the processes by which the program worked. So our SBAT APN, that was Courtney. Upon referral, she would contact the caregiver to review the program, get their consent. She then would work with the asthma care provider to get detailed clinical information on the child, and then work with the pharmacy to submit those prescriptions, the prescribed meds, work with the insurers to get those the approvals that we needed for both controller medication and quick relief medications to be sent home in school. Then liaison with the SBAT nurse on our team. She would then connect with the school nurse, bring them up to speed on what was going on with the program, the children in her school that would be enrolled, as well as communicate with the caregivers. So it really is like a hub and spoke mechanism where our SBAT nurse is in the middle and acts as kind of that liaison to all of the different stakeholders in the program. That's not to say that we didn't encounter challenges as we tried to implement this program in a real world setting. As I stated earlier, it took us over 18 months to get that waiver from the State Board of Pharmacy in order to mail the prescriptions to the school. It took over 12 months to get Medicaid approval for those dual controllers each month for the kids. The other thing that we had not anticipated was by now having this huge volume of both controller and quick relief medications, the actual storage capacity in the outpatient pharmacy for all of these meds to prepare, because they weren't meant to be a mail order delivery service. So we had to work with them to increase their storage space, as well as create an internal tracking system to manage those mail order prescriptions. We had to work with the school personnel because they really weren't clear on who was eligible for the program and who was not. So we worked with them on how to identify the kids that would best benefit. Some nurses initially were worried about, would it create extra burden in their already chaotic workday? And then there was some, as Dr. Allen was going out and meeting with the various, both primary care as well as specialty care physicians, there was some concern initially that the program would be quote unquote stealing their patients away. And what she basically had to educate them on is, no, that's not the case. What we're actually doing is we're actually providing additional services and acting as an extension of the care that you are providing for the patients that would be in this program. So kind of basically saying, hey, look, you're getting free help from us, and we're going to communicate back to you, what we're doing with your patients. So pre-COVID, where we got to, our first year that we launched in 2013, we had 13 schools with 76 kids enrolled, which I thought was pretty good for just an initial, boots on the ground, not a lot of advertising. And the majority of the participation was triggered by a child with uncontrolled asthma that the nurse, we call them frequent flyers, that were constantly going down to the nurse's office for their quick relief medication. But then we saw a really unique phenomenon happen. The school nurses, it's a tight-knit group, they talk among themselves. And what would happen is, as they saw that it actually made their workload easier, because as the kids came in the morning and they lined them all up and gave them their control and medications, 9 times out of 10, they didn't even see them the rest of the day. So it's not like they were coming down 2 and 3 times a day for quick relief. And it was like, oh, wow, this makes life a whole lot easier. Word of mouth spread about how much this program helps those kids with asthma and helps their workload. We also organized an asthma conference through Nationwide Children's Hospital, where we have a half-day session dedicated to school-based health. So that was another way that we got word out about the program. And we offered scholarships for school nurses to come to that. The other way that we got the word out is sometimes as children change schools, they didn't want to give up participating in the program. And so that's how we got other nurses to join. And then lastly, there was actually referral of students by their healthcare providers, caregivers, or community workers. So it was a multifaceted kind of spreading of the program, which was great. And then in 2016, I got a small grant to do a needs assessment to really look at, all right, if we want to scale this program up, what do we need to do? And I wanted to hear from the people that had already been involved, what were some of the things that helped you launch the program, but also what were some barriers to implementation so that we could really think about how do we best, build this up so that we could do widespread dissemination. And then prior to the COVID shutdown, by the school year 2019-2020, we had enrolled 286 schools and over 900 kids, which was absolutely phenomenal if you think about that short period of time. And at that point, we had built the SBAT team to go beyond just Dr. Allen and Courtney, but to also include 6 nurses, 1 part-time pharmacy tech, and 1 full-time program administrator. And then it took me 4 years and 4 tries. But in 2019, I finally got a $2.8 million grant from NHLBI to now go back and do a rigorous implementation evaluation. Because what we wanted to see was, okay, Jill had done a number of randomized controlled trials over the past decade, each of which doing different iterations, some with telehealth, some going into adolescent, now bringing in specialty care. All of the RCT data showed improvements in clinical outcomes, decreases in school absences, and the program was demonstrated to be cost effective. But all of the work that Jill has done to date have been these rigorously controlled clinical trials. So what we wanted to do was say, okay, have we seen the same positive impact of this program when we've implemented it now in a real world setting? And as luck would have it, just as we got the funding and we were gearing up and hiring staff and training, COVID hit. Yay! And disrupted everything. So our program was shut down for a while, but I want to share with you before we get into what we did after we were able to get back up and running, some of the positive outcomes that we did demonstrate pre-COVID. So as you can see here on this slide, we had significant decreases, 33% in ED visits in the 2-year period pre-enrollment to the 1-year period post-enrollment. We had almost a 52% decrease in inpatient stays. from 1 year pre to 1 year post. 56% decline in, oh, I'm sorry, that was the inpatient stay, sorry. Hospitalizations, PICU, we had another massive decline in PICUs, almost 86% from the 2 year pre to 1 year, and 93% 1 year pre to 1 year post. So this program is making a huge impact on children's clinical and physical health. Now, what we don't know, and what we're doing in our new study that we're doing right now, is we are actually accessing academic data, and I'll get to that in a little bit. But as you can see here, we in our, and again, this was just early enrollees, this was only a sample of 98, are already demonstrating significant clinical impact of the program. We did another analysis where we had ACT scores, which is the asthma control test, which measures the level of symptom control in the kids with asthma. And we had 198 kids at the time we did these analyses that we had ACT scores both pre-enrollment and post-enrollment. And in this asthma control test, the higher the score, the better. That means the more well-controlled the child's asthma is. And what we see here is that we had, again, a very substantial improvement in their asthma control scores from 16.2 to 21.37. Anything over 19 is considered well-controlled. So not only were these findings statistically significant, but they were clinically meaningful. So all that being said, we have all of these great outcomes. And then COVID hit. As we all know, the world stopped in March of 2020. And in Columbus, all public schools were closed on March 16th, which in essence, because kids get their medications as part of this program in school, that basically shut down our program. So what our nurses did is they scrambled, they went and they retrieved all of the kids' medications from school, because nobody knew at that point in time how long this was going to last. So they mailed them or they delivered them to the kids at home, so they at least had additional supplies on hand. But then the challenge that we were hit with was that the majority of that SBAT nursing team, because the program was shut down, got redeployed to other roles within the hospital. So they were doing things like managing employee health, because all the employees had to be screened as they came into work. They were running phone triage. So they got redeployed, and basically we lost over 50% of our SBAT nurse team. The nurses that did stay on board, what we did is we had them stay in touch with the caregivers so that we could monitor when the children needed refills, how they were doing with their symptoms. Because again, COVID was a respiratory disease, and early on, we were all panicking about, oh my gosh, what does this mean for our kids with asthma who already have respiratory issues, right? We were really concerned that this was going to hit these kids very hard. The one thing that did happen, though, is the charter and private schools in Columbus remained open throughout. They never shut down throughout the pandemic. They did, other things. They did other public hygiene things, but they never fully closed. And so for those schools that the SBAT program was operating in, our SBAT nurses continued to deliver the program as normal. In January of 2021, the public schools resumed limited in-person instruction using a hybrid format. So the kids were in school 2 days a week, another group of kids the other 2 days. Wednesdays were reserved as a full cleaning day. But then summer of 2021, preparations were underway for full-time in-person instruction and re-implementation of our SBAT program. Our research project was still shut down, however, because we had not yet resumed in-person instruction. One of the challenges that we ran into when we wanted to get started with the research project was that initially the school nurses were thoroughly overburdened with having to do contact tracing. As the kids came in, they had to, it was a hot mess in terms of anybody that got exposed got sent home. They had to do all these calls for contact tracing. So we made the decision to not overburden them. And we said, you know what, we're going to put the pause on re-implementing both the program as well as enrollment into the study. We were able to, in November, the nurses had complained enough and they got relief where they no longer had to do the contact tracing. So we were able to build our team, the nursing team, back up to our peak COVID levels, and then begin to lay the groundwork now for actually starting our research project. So now I want to shift and now go into what are we doing right now that we've been able to actually get the program back up and running at full speed, because there's no way to evaluate it when it's not being delivered in the way that it was intended to be delivered. And I want to thank my funder, NHLBI, for the grant that we finally did receive, as well as working with us to kind of redesign some of the things that we had originally planned now that we had a shortened time period in order to get this work done. So the primary aims of our program implementation evaluation are, we wanted to conduct a longitudinal pragmatic trial evaluating the clinical, academic, and cost effectiveness outcomes when we implement this in a real world setting, but also examine the implementation success. What worked, what didn't, because what we want to do is build a toolkit as part of AIM 3 that we can then make available to other schools that might be interested in doing this at the same time. Part of this pragmatic trial is going to involve online surveys where we're going to get obviously demographic information. We're using a standardized, it's called the asthma related quality of life tool. We're going to get that information. We're going to get information on their asthma illness beliefs and medication use. We're going to ask for subjective reports of caregiver work absences due to the child's asthma, school absences due to asthma. We're going to capture healthcare utilization, both self-report and from the EHR. We can't rely solely on the EHR because even though Nationwide Children's Hospital in the Columbus area has a very large network of care, we know that some of the kids may have gone outside the system to get either acute care or emergency care. And then we're going to be doing full medical record reviews as well as academic record reviews on the kids. And this is a unique partnership that we have with the Columbus City School Districts. And I'll give you some updated information on where we're at with that. For number 2, we're going to assess satisfaction with the SBAT program. We're going to look at contextual factors that facilitated or impeded both initial implementation, so pre-COVID. And then we also have a very unique opportunity, given that, at least in my lifetime, I've never lived through a pandemic before, where a very successful program got thoroughly interrupted and had to be re-implemented. So we're also going to be gathering information on, okay, when you wanted to restart this program, again, what helped, what hindered? What were some solutions that you came up with to overcome some of these challenges and barriers? And then additionally, what are the required resources that if we wanted to scale up dissemination that we would need to consider? And then our last aim is to take all of this information and develop a multifaceted national dissemination strategy for the program. And we're already starting, part of what I was able to get done during the COVID shutdown when we couldn't do a lot of the pragmatic trial or anything, was begin to build out a website. And we're going to have components for caregivers and their kids, healthcare providers and school administrators, personnel, insurers. We're partnering with the National Association of School Nurses so that we can showcase this innovative model of care delivery and integration, because we really want to make this kind of the national standard for delivering school-based asthma care to kids throughout the country. So some of the things that we had to do to kind of reframe this because of the COVID interruption is we now are doing a 6-year retrospective medical and academic record review covering the period 2013 from when we implemented the program to 2019. We decided to stop it at the end of 2019, given the fact that there is some emerging data that COVID was actually here in the US in December of 19, but we didn't really know what it was then. So we decided not to muddy the water by going into 2020. We are still doing that longitudinal natural experiment from 2022 to 2024. And now we've had to cut our sample size down, given that we no longer have 5 years to do the project. So we've cut it back to 300 children and their caregivers ages 5 to 18 who have enrolled in our SBAT program. The caregivers are going to complete 3 online surveys at the time of enrollment, at the end of the academic year, and then at 12 months post-enrollment. And we did that because we want to see also during the summer, do they maintain their asthma control and stay on top of their medications? We'll be doing the medical record review to abstract acute and ED visits and hospitalizations. We're doing a pharmacy record review to get the number of fills and controller and quick relief meds. And then this is where we have this very unique opportunity, because to date in the literature, in the asthma world, when we talk about the impact on schools, it's really all about absences. But we know that kids miss school for any number of reasons. And we have a unique opportunity now where we can actually get missed instructional hours, we can get grades, and we can get disciplinary actions for these kids. So I'm really excited to dive into those data in the not too distant future. We will be doing, I'm doing that actually starting next month, 10 key stakeholder interviews. And then we've also had one round of focus groups last spring. We'll be doing another round this spring, where we're interviewing caregivers, kids, school personnel, so the nurses and the medication monitors, and we're getting their feedback on the SBAT implementation, also re-implementation, facilitators and barriers, required resources, and then any suggestions from them, from all of these stakeholders, on what might we need to change in order to make this program, more successful and more widely adopted. The stakeholder interviews are going to be with the CEO of Partners for Kids, because we want to come up with a financially sustainable model. As we know in doing research, the one thing, and for me as a community-based researcher, the thing that always is awful is when you've demonstrated that an intervention works really, really well. And then when the grant ends, that intervention or that program ends because there's not a sustainability mechanism built in. So I've been working, Dr. Gleason is now the CEO of Partners for Kids, and I've been working with him over a number of years to build a model where for these Medicaid funded kids, where it's a capitated program. So he gets X number of dollars every year per child. And the idea is that any money that we save by keeping that kid out of the ED or out of the hospital would get reinvested back into supporting the SBAT program. So we're working very closely with him. We're working with, as I said, the National Association of School Nurses. I'm going to be interviewing the outpatient pharmacy head to talk about what were the challenges and barriers to now having to kind of pivot and also become a mail order service. We're going to be working with the school administrators to find out, what does it take? What resources do you need on your end? And we want to be able to give back to them as well. What's in it for you in terms of the outcomes for their children. We're also going to be doing the key stakeholder interviews with community providers as well to get their perceptions and their feedback on how this program is supporting them and or what barriers there may be. And then lastly, we're going to be doing a cost effectiveness analysis where we're going to look at 4 categories of costs. We're going to look at the program costs, the healthcare costs. We're going to look at school attendance fee losses. If you're not aware, when a child is absent from school that day, the school loses federal funding dollars as a result of that absence. So again, a goal is if we get these kids' asthma under good control, they're sleeping, they're not sick, they're going to school, the schools don't lose money as a result of that. And then we're going to look at caregiver productivity losses. Those of you that have young kids, and I had a daughter with asthma, when they get sick, somebody has to stay home. And so there's a way that we can model when that caregiver has to take time from work to stay home with a sick child, what those productivity losses are to society. And then, as I said, one of the things that we're working on, that we were able to work on over the COVID shutdown, was the website. We already have a logo developed, as you can see here. That's where we're going to house all of these publicly available program materials and resources for the different stakeholder groups. We plan to have, and I'm working on that this summer, a program implementation manual. It will be downloadable, and it's going to provide guidance on the steps required to successfully develop and implement the program across the different stakeholder groups. We'll have an intervention manual that's going to have information for the school nurses and other personnel on guideline-based asthma treatment and management, what the SBAT intervention content looks like, what are the required documentation elements that you need to have, the timing and the content of communication among the different stakeholders, and the necessary reporting. And then lastly, we're going to have educational materials that are going to be developed for each of the stakeholder groups. So we've already developed some brochures for caregivers and their children, healthcare providers, and schools, and they're all going to be in a downloadable PDF format. The other thing that I would eventually like to do is work with the team to develop national guidelines for this directly observed therapy of children's controller medications in school, because to date, none exist. We want to propose to the school asthma subcommittee their inclusion in the National Asthma Education and Prevention Program. And what we'd like to do as part of that is convene a panel of clinicians, school administrators, and then representatives from that National Association of School Nurses, plus our team, to work on developing those guidelines. We're going to have linkages to social media. We'll have these informational brochures, the guidelines. We're going to have evidence fact sheets once we get done with all of our quantitative data analysis. And then we hope to develop policy statements. As I said, you saw some of the challenges we had around Medicaid reimbursement for dual canisters for the kids. The issue that we ran into with the Board of Pharmacy not allowing us to mail to the schools. These are things that I think we need to change. You know, they serve as impediments to delivering care to the kids in school. And we know now that, you know, more and more children are being diagnosed with chronic conditions, which means more and more school nurses are being tasked with managing those conditions during the school day. So where are we right now? As I said, we were doing this retrospective review. As of last Thursday, we have pulled 4,575 academic records for kids. As you see, we have almost 110,000 absences pulled and coded. We have over 10,000 behavioral incidents pulled, and we're working right now on the incidents. They have levels of severity, you know, so I'm not really interested in, you know, a kid that got written up because they had a uniform violation. My theory is that when we get these kids under good control as a result of participating in this program, they're sleeping better, they're not having symptoms, they're less irritable when they get up in the morning, so they're going to be less disruptive in the classroom. And that's what I'm really interested in. So we're working on getting those behavioral incidents coded. And then we've already run a beta test on 100 of the medical record data abstractions. We wanted to make sure that we were pulling the right data for the right kids from both the EPIC medical record system as well as the PFK claims database for their medications. Our Pragmatic trial enrollment began September of last year, and to date we've got 188 child and caregiver dyads consented. Our goal was 150, so I'm excited to say that we exceeded our target number. We have completed 100 baseline interviews. Our next cohort will be enrolled next September, but we'll be getting ready as we're coming up at the end of the school year. We'll be getting ready to start deploying the end of the school year surveys to the caregivers and the kids. As I said, we completed our first round of focus groups last spring. All of those transcripts have been coded, and we're in the process of doing the analyses right now. Oh, my question. And then I said we will be doing, in addition to the focus groups, we're going to be doing the key stakeholder interviews this summer as well. We have the website architecture developed and the content is drafted. We've also got those downloadable PDF materials for the caregivers, the schools, and the nurses. And I gave you just some screenshots here. So the first page that you see here is the home page, the home landing page, where I love the tagline, because this is all about, and this is what I wanted for my daughter when she was little, is just, we just want them to be kids. We want them to know that you can go run, you can go play, you can go outside at recess. But as you can see here in this first panel, we then will have sections for each of those key stakeholder groups. So we're going to have information for school nurses and staff, for healthcare providers and caregivers. We also have developed our this about program. This is our about landing page. It gives a little bit of a description about the SBAT program. And then we have another where it's actually got the resources. And this is where all of those downloadable documents and at some point in time, videos will be housed for the different stakeholder groups. This is the guide for school nurses that we developed. We've got, I just gave you the table of contents because it's quite lengthy. But you can see that it's got all of the key elements of what they need to do. And the implementation manual will take this and more fully develop all of the information that they need to know in order to deliver the program in their schools. This is the caregiver brochure. It's a trifold brochure that we developed for the caregivers. So again, it gives them just some information on what are some common triggers for their child's asthma symptoms, and then a brief overview of what the program is and how it works. This is the outside of the trifold. And then this is the inside when you open it up. So in our world, we give every family an asthma action plan. And this is a sample that, again, we want to give it to folks that they can then tailor it to either their own institution, their own practice, but it describes what the asthma action plan is. It says what to do when certain symptoms are apparent with your child. And then there's a how-to in terms of how to correctly administer your child's controller and your quick relief medications. So our overarching goal is that we want this SBAT program to be a cost-effective, easily tailored program that school districts across the entire US could easily implement. My firm belief, given some of the, not only our data, but all of the data that Jill has generated to date, is that we have a huge potential to dramatically improve controller medication adherence and subsequent health and academic outcomes for these kids. So I'm hoping in another year or so, I'll be able to come back to you guys and give you all of the amazing findings that we are going to generate from this program. And once again, here's my contact information. And I just really want to thank all of you for the opportunity to share, as you can see, what I am so passionate about, but also, hopefully have given you some idea of what does it really take to do a community-based intervention and implement it outside of the constraints of a randomized controlled trial. Because it's not easy, but it's fun.
Fantastic. Thank you so much. That's great.
And so I'm going to stop sharing, Sharon, so that you can grab the screen back.
Wow, that was what an undertaking. That's so impressive. I'm curious. Were there meetings with other community partners at the beginning of the study before you started developing your programs? There's a lot of emphasis now on engaging community partners when the study is being planned, in addition to using their feedback for implementation.
Yeah, absolutely. We met with the local chapter of the American Lung Association because that is a widely used resource particularly by caregivers. We met with them again to partner with them on sharing resources, referrals to their organization. What was the AAF, American Academy of Allergy, Asthma, and Immunology is another group that we partnered with. So yeah, we did do some of that more local community-based, and again, many meetings with the school districts as well, to really figure out what's going to work in your setting, outside the constraints of a randomized controlled trial or research study.
Okay. And then another question I had is, my understanding is that the guidelines for treatment, at least of pediatric asthma, are maybe changing in that controller medications are now being recommended to be used on an as needed basis, as opposed to once or twice a day administration, even of inhaled corticosteroids.
Yeah, you mean the SMART guidelines now?
Yeah, that's, well, if they're smart, I think they're smart.
Yeah,
and
so
this is causing havoc in my world, which is the world of adults with lung disease. How are you
Yeah.
managing that?
Well, okay, so we all have to look for silver linings when bad things happen, right? So the good thing was with the COVID shutdown of both the program and our project, it happened to kind of dovetail a little bit when we knew that those SMART guidelines were going to be released. So we were actually able to do some work behind the scenes before re-implementing our program to do some of that revamping of what we needed to do based on the new SMART therapy guidelines. Now, they don't apply to all kids, but it is a very dramatic change from the way we've always done things. And so not only were we having to do education now with the school personnel, but our SBAT nurses were also having to educate some of the primary care providers that, they have busy clinics. They're not going to take the time to become fully knowledgeable about all of these changes based on the SMART guidelines. And so that's where I said, we have this hub and spoke, and that's where those SBAT nurses with this new change, which for those of you we didn't mention, that those guidelines came out in 2020. That's where those SBAT nurses have played an absolutely crucial role, like I said, in educating not only the school personnel, but the primary care providers as well.
That's spectacular. That's great. I see another question is, can this model of school-based treatment apply to other chronic conditions that are seen in pediatric populations?
I just had, when we did the focus groups last year, I had an opportunity to touch base since I was in town with Amber, who is the director of school health services in Southwestern City School Districts. And we were talking about adapting this exact type of model for kids with diabetes, kids with sickle cell, and kids with ADHD. Those were the three that she named, and again, I'm listening to her. She's the stakeholder. I want to hear, what do you need? And we were talking about how easy it would be to just tailor this delivery model for those conditions as well. Yeah,
Wow.
so I think it easily could serve as a model for a number of other chronic conditions. Yeah.
Wow. Fantastic. And then I see a question is, are you going to be looking at some of the social determinants of health in terms of how that might be affecting your outcomes? For example, I don't know, like zip codes, for example. If a child lives in a neighborhood where there's a lot of noise or air or environmental air pollution or stress, economic or whatever stress, that how can you factor that in when you look at your outcomes?
Yeah, we didn't plan on doing the external environment type of thing, but we are collecting all of what, as a health disparities researcher, obviously I'm collecting a lot of the family level social determinants of health. But we will have zip codes for all of the kids. So that would absolutely be something that we could definitely do another analysis on. The other thing is the majority of these kids, it's about, in Columbus City schools, it's about 94% of the kids are eligible for free and reduced lunch. It's about 92% in Southwestern. And we do have quite a bit of ethnic diversity. So Southwestern, if you look at a map of Ohio, and Columbus is literally smack dab in the middle. Southwestern City School District sits southwest of Columbus, but that is an area where there is a huge population of Latino families. So that's where that's the predominant ethnicity in that school district. And again, they're about 92 to 94% free and reduced lunch. Columbus has seen a shift. For those of you that don't know, Columbus is the second largest Somali immigrant population next to Minneapolis. And so and I don't like grouping people into big buckets, but the way they capture their data are, we have the predominant racial/ethnic group is Black, but there's subcategories within that in Columbus City schools. So we will be able to look at, and we do have in the demographic data, we do have US versus foreign born, so we can look at some of those. We do get household environmental triggers. We don't get air quality, but just the typical things that we assess, you know, pet dander, kerosene, wood burning stoves, cigarette smoke, things like that.
Okay. Let me see here. And do you anticipate bringing this program to Rhode Island?
I would love to. I could, like I said, I want to see this in every school in every state. We do have a collaborator in Massachusetts through Boston Children's who she's tweaked it a little bit, but she's actually doing it more in her clinic, but reaching out to the schools in her area. But yeah, I just don't have any connections with schools here. So if any of you want to send me folks that I should connect with, that would be great. Because again, it's the feedback from the nurses is that they love it, because what they've been able to do now is it's helped them free up time, because they've developed, many of them, what they tell me is that literally as soon as the kids get off the bus or get dropped off, they now have them trained to you come to the nurse's office first, you get your meds, you wait, and then you go have breakfast, and then you go off to class. And then they don't see them again the rest of the day, unless maybe if they're in sports after school, they might come. We don't recommend it, but they might come down to get a pre-treat with albuterol.
Okay, fantastic. Any other questions from the audience here? I'm not seeing any. Well, so thank you so much. This was a very interesting, and I have to say, daunting in terms of the logistics,
Yeah.
clinical study that clearly is going to have important implications for human health for these children. So that's wonderful.
Yeah.
And I wanted to point out that our next speaker in this series will be on May 11th, and that's going to be Greg J., who is an emergency medicine physician who will be talking about his research on a very interesting compound, lubricant. So we'll look forward to seeing you all again next month. So thank you once again.
And again, thank you for the opportunity. As you can see, I'm quite passionate about this. So any chance I get to spread the news, I'm happy to have that opportunity.
Fantastic. Thanks. Bye-bye.
Thank you again. Take care, everyone.